In this lecture, we will discuss hyperkalemia, including some potential causes and EKG features at different potassium levels. Potassium has an important role in both depolarization and repolarization. For this reason, potassium disturbances can cause dramatic EKG changes. What's clinically useful is that plasma potassium levels actually have a strong correlation with the EKG changes we see and the risk of arrhythmia. Therefore, the EKG can be used to give us an idea of the severity of hyperkalemia. High levels of serum potassium slow the impulse transmission throughout the entire heart. Severe symptoms tend to occur once levels reach 7 millimole per liter. And there are a number of causes for hyperkalemia, including renal failure, acidosis, hemolysis, muscle damage, insulin deficiency, as well as Addison's disease. Other contributors include medications such as ACE inhibitors, angiotensin receptor blockers or ARBs, and potassium-sparing diuretics, as well as digoxin toxicity. So, as we said, we can use the EKG to approximate the severity of hyperkalemia. Therefore, we will look at the different EKG features seen at different potassium levels. Mild hypokalemia begins once potassium levels go beyond 6 millimoles per liter. The earliest sign of hyperkalemia is pointed T waves, which are tall and narrow at the top. They tend to be most prominent in the precordial leads. So if you look here, and you can follow along. We're looking now at the mild hyperkalemia, and we see these pointed T waves. The earliest sign, you'll see these tall, narrow T waves that are most prominent in the precordial leads. So here, this is normal potassium levels. We see our normal complex, and as our potassium levels increase, we'll see how the changes affect. Okay, the earliest one we see are these pointed T waves. Here's our T wave. Notice that they become pointed, okay? They're tall. Here's our normal T wave. So you can see the increase in our T waves, and they become pointed here at the top. So those are called pointed T waves. In patients with left ventricular hypertrophy, there may be instead normalization of secondary T wave inversions in the lateral leads 1, AVL, V5, and V6, okay? So if you recall, with left ventricular hypertrophy, if it's really significant, you'll get those, the ST depression T wave inversions where you can have that strain pattern, we call it. Now in this case, if you have hyperkalemia, you can see more of the normalization of the secondary T wave inversions in those lateral leads, which may suggest hyperkalemia. Okay, so as potassium levels continue to rise, moderate hyperkalemia shows more prominent T wave changes. The P waves become wide and decrease in amplitude. The P wave may even become difficult to make out at this point. The PR interval will lengthen, and occasionally sinoatrial block may occur. Even second-degree AV block or third-degree or complete heart block may develop. ST elevation may also occur in leads V1 through V3. In patients with WPW syndrome, which is Wolff-Parkinson-White syndrome, the delta wave that's characteristic of it from ventricular preexcitation may disappear as transmission through the accessory pathway stops. Remember, the impulse transmission is slowed throughout the heart, including any transmission through the accessory pathway. Okay, we mentioned earlier that this high serum potassium levels slows impulse transmission throughout the heart. So even those accessory pathways that we see with WPW syndrome, that delta wave may be absent in those cases. Okay. So now with these moderate levels, what we're saying here is that we see our P wave. This is our P wave. This is our normal P wave, okay? Not affected yet. Our T waves affected initially. Now we're seeing the P waves decrease in amplitude, okay? Which is this arrow here, noticing that. And notice that we have our P wave width, okay? So if you imagine our complex here, so the first changes were with these T waves where they went up. Now we're looking at our P waves going down, and they're also getting wider. Okay, and we also mentioned that we can have AV block that may occur in which our PR interval is getting even prolonged. Okay, we mentioned we can even have second or third degree complete heart block. Okay, so notice that our PR interval is lengthening here in this case as well. Okay, and we also said ST elevation, which we can see here. So notice that our ST segment flat in this case, and now becoming elevated. We can see that sometimes in leads V1 through V3, which we mentioned in this case. Okay, so increase in the P wave duration, decrease in the P wave amplitude, increase in the PR interval with or without AV block, and then these ST elevation changes in the right precordial leads V1 through V3. Remember, WPW syndrome, you can sometimes see a loss of that delta wave because we have impulse transmission that's slowing throughout the heart. Now, if potassium levels continue to rise such that they go beyond 7.5 millimolar per liter, the aforementioned EKG changes will become even more prominent and the QRS interval will now lengthen. Okay, so at these more severe levels, we see an increase in the QRS interval. Okay, so here's our QRS interval lengthening at this point here. Notice it's getting wider. So this is our QRS interval. We're saying that it's going to get prolonged. Okay, so widening of that in more prominent features of the 4-1. So notice here's our P wave getting even wider and flattened in this case. Okay. Now, if potassium levels are still not controlled, the QRS complex may eventually fuse with the T wave, forming what we call a sine wave, which can then develop into ventricular fibrillation, or VFib. So if you notice down here, notice our QRS complex, this is fusing with our T wave, okay? And what we get here is almost this sine wave that's appearing, and you'll see that throughout, and that can eventually develop into VFib, which obviously can be is a life-threatening arrhythmia. Okay, so let's review what we discussed before we end here. So hyperkalemia results when we have an increase in serum potassium levels. And remember, everything is slowing down, so it slows impulse transmission throughout the entire heart. Okay, and one thing to note is that how this can help us is that these potassium concentrations are correlated, the severity of how bad the hyperkalemia is correlated to the EKG changes as well as the risk of arrhythmia. Okay, so this is different from some of the other electrolytes we look at. This can actually be useful to us. We mentioned a number of causes: renal failure, acidosis, hemolysis, muscle damage, insulin insufficiency, as well as Addison's disease. We mentioned some medications, ACE inhibitors, ARBs, as well as potassium-sparing diuretics, okay? As well as digoxin toxicity can lead to this too, okay? Because remember, digoxin competes with potassium for that sodium-potassium ATPase, okay? Now, remember, the EKG features are based on the severity of hyperkalemia, okay? With mild hyperkalemia, we see those pointed T waves, which are the earliest sign, okay? Those pointed T waves are tall and narrow. They're these ones here, and they're most prominent in those precordial leads where you'll see them the most. Okay, and notice in our image here, before we were talking about calcium, now notice our potassium here. So if we're going up in potassium levels, we're going towards the positive, and notice that our T waves will get larger. Okay, so this is a basic recap you can use for electrolyte disturbances, okay, for all of them. So if we increase potassium levels, our T waves become pointed, and that's the earliest sign that we see. Okay, and the most common one you'll hear talked about. Now, if the patient has left ventricular hypertrophy, you may instead see normalization of the secondary T wave inversion in those lateral leads 1, AVL, V5, and V6. If there's moderate hyperkalemia, what you next see, okay, as we move on and our potassium levels start to increase, we see flattening or decrease in amplitude of the P waves. The P wave duration increases. The PR interval can increase to the point that we start to see AV block, as well as we can see ST elevation, or ST segment being elevated in leads V1 through V3. If the patient has WPW syndrome, we can see loss of the delta wave. Okay, remember the delta wave represents ventricular preexcitation down that accessory pathway, and if we have slow transmission throughout, that means transmission through that accessory pathway will also slow down to the point we may not even see it. Okay, so that delta wave can disappear. If we have severe hyperkalemia, where potassium levels are not controlled, we can start to see an increase in our QRS interval, and eventually a sine wave can develop, as we saw here. And if that's still not controlled, we can get VFib, which obviously is life-threatening. Okay, so in this lecture, we discussed the hyperkalemia, and we talked about potential causes and EKG features at different potassium levels. I think this is really clinically useful, and I really hope you learned something.